like to review the functions.
Yeah, members, we are calling the meeting back to order. Thank you, members. And we are 7 p.m. Thank you, members, and so forth. We have two bills here yet for this evening. And the first one we're going to be taking up is House File 1934. So Representative Reyer, would you like to, as you approach, I would assume you would love to move your bill before the committee.
I would adore the opportunity.
Adore, whoa, that's a big word.
We cannot wait.
Okay. Let me know when you're ready, Representative. Okay, Representative Reyer, I believe you have a DE2 amendment. Members, is there any discussion to the amendment? Representative Franson.
Thank you, Mr. Chair and members. This will be probably the last time I think I speak tonight. So while single payer administrator always looks good on paper, but does seem to have some problems once implemented. And we discussed those details last year, but somehow a single dental administrator law still passed. I am grateful for the work that you are doing, though, addressing the issues. And which is the delay in the bill, right? So grateful for the delay in the bill. But Critical Access Clinic in my district, who does incredible work of serving the MA population, is extremely concerned about the shortening the delay. Their number one concern is shrinking reimbursements, leading directly to loss of access. Loss of access means the community they serve end up in the emergency room with far worse outcomes at a far greater cost to the state. It is vital that these rural critical access providers be involved in the working group and have an equal voice in the working group's recommendations and the ability to provide feedback to the legislature in case the department's report is not consistent with the working group's recommendations. So I do have some ideas for you, Representative Reyer. So I think that the bill could be improved by allowing county-based purchasing, or in lieu of that, insisting that the working group DHS does a cost-benefit analysis of the existing county-based purchasing system, specifically creating a spot on the working group for a smaller, exclusively rural clinic, critical access clinic, and ensuring a sufficient delay to make sure all parties are prepared for implementation. And so I hope that these issues can be taken care of. I lost the rest of my notes here, hold on. And then also creating a formal and ongoing stakeholder group with authority to bring suggestions to the legislature in future. So hopefully, as this bill moves forward, we can take some of those and incorporate them into your bill to give more comfort language to the critical access dental providers.
Okay. Seeing no further questions or debate here, all those in favor of the DE amendment say aye.
Aye.
All those opposed say nay. The motion prevails and the amendment is adopted. Okay. Representative Reyer, introduce your bill as amended, please.
Thank you, co-chairs Backer and Bierman and committee members. House File 1934 changes the timeline for adopting the single dental administrator from January 1, 2026 to January 1, 2028. This will protect the stability of the dental safety net dental system and help avoid a breakdown in access to care for Medicaid and MinnesotaCare members. The bill requires a work group, potentially the Dental Services Advisory Committee or Subcommittee, to provide recommendations for the following: a dental payment rate structure that promotes consistency while also accounting for geographic differences in access to and cost of dental services, critical access dental status, and patient characteristics, which includes a number of factors. An infrastructure strategy to help the provider community continue to develop their dental capacity. A more advanced measurement strategy so that in addition to the current metric, we're obtaining a more complete view of dental system performance. goals and process to ensure coordination of care in the newly structured system, and workforce strategy to support the pipeline of dental caregivers at all levels. Timelines to implement these recommendations will be developed as part of the final language. Some of these, moving forward, would be implemented by DHS, while others are outside the scope of the agency to implement. I'm working through TA with DHS to make sure all expectations are clear and workable. I've had many conversations about this bill, and there are many more to come, and I'll look at Representative Franzen when I say that. During the next few weeks, we'll address open questions and fine-tune the approach, and I look forward to that work. In closing, I must note that I don't bring this forward lightly. I'm deeply committed to structural health care reform and was very happy in 2021 to see the single administrator language passed. Yet even in normal times, I had the same reservations that this bill addresses. And now aggressive cuts by the federal government on health funding and staffing add a concerning level of unpredictability and an additional level of urgency. Cuts have already carried over into Minnesota, and I'm even more deeply convinced that we need to be mindful of the risk to an already fragile system. Nonetheless, we'll continue to move this forward, and because of the tasks in the intervening 2 years, we'll have a more robust and sustainable approach when we make the switch to the single dental administrator model. Thank you, Mr. Chair.
Okay, testifiers. So please state your name, and we would ask you to keep your testimony to 2 minutes, please.
Thank you, Mr. Chair and members of the committee. My name is Dr. Michael Helgeson, and I'm the CEO of Apple Tree Dental. And I'm also serving as the treasurer of the Association of Critical Access Dental Providers of Minnesota. And I want to thank Representative Reyer for her tireless work to ensure that every Minnesotan has access to dental care. There are roughly 300 critical access dental providers across Minnesota, and they deliver more than 2/3 of all the dental visits for the 1.5 million people that are enrolled in public programs. And our association was formed last year to be the voice of the critical access providers across Minnesota, urban and rural. CAD providers have developed efficient and innovative care delivery models. For example, Apple Tree brings mobile care to low-income children in schools and Head Start centers, to individuals with disabilities in group homes, and to older adults in long-term care. As you may recall, in 2021, the legislature passed a dental access performance benchmark to be achieved by 2024. DHS was instructed to contract with a single dental administrator beginning January 1 of 2026 if that benchmark was not met. And although the 24 data isn't available, DHS is rapidly moving ahead due to this legislative mandate. But the reality is that a complex administrative change simply can't be accomplished in just a few months without causing irreparable harm to the very fragile network of critical access dental providers. So if House File 1934 does not pass, in just 9 months, the critical access providers will experience devastating cuts to their reimbursements ranging up to 44%, the loss of critically needed grants that fund clinic updates, workforce recruitment and retention efforts, and much more, the loss of support for unique mobile hub and spoke delivery models that are really dental lifelines in certain rural communities. And lastly, the loss of medical dental care coordination, which improves health outcomes and lowers total costs. House File 1934 establishes a work group and a timeline to prepare for a successful change. And as was stated, with federal Medicaid policy changes pending, now just isn't the time to make such a dramatic change that would have profoundly negative impacts. So I want to close by thanking Representative Reyer and all of you for taking the time needed to prevent unintended harm. Our association looks forward to working with the committee, and I'm happy to answer any questions. Thank you.
Thank you. Next testifier, please state your name and 2 minutes, please.
Co-chairs Backer and Bierman, my name is Dan Murphy with the Minnesota Dental Association, the statewide association for dentists. Many of our members participate in Minnesota healthcare programs, including private and nonprofit dental clinics, with many identified as critical access dental providers. While the concept of a single administrator for dental services under Minnesota healthcare programs was not a particular bill or issue that our association brought forward, our membership has supported this concept as a means to improve administrative efficiency and transparency. A 2022 DHS legislative report identified several reasons why dentists are hesitant to participate. Those included low reimbursement rates, inconsistent care coordination, multiple prior authorization processes, and administrative burdens that vary across the fee-for-service, managed care, and county-based purchasing models. Our members have firsthand experience with these challenges, and a single administrator has the potential to simplify and improve the system. Under current law, reimbursement under a single administrator defaults to fee-for-service rates, significantly lower than what many providers receive today under the current system. Minnesota's dental reimbursement rates are still based on costs from 1989, a long-standing issue that we have sought to address. Absent rate increases or changes to how reimbursement under a single administrator is determined, our organization supports a slight delay in implementation. Removing lines 2.4 and 2.5 in the DE, which is that fee-for-service reimbursement line, it's a step in the right direction. While our support for the single administrator remains, it is important and it is apparent that there are further details in addition to the rates that need to be addressed to make sure that the transition goes as seamless as possible. So our mutual priority is to get this right, building a system that strengthens provider participation and enhances patient outcomes. It's a big transition and we want to make sure it's done well. So at this time, we would still support a delay while these issues are being discussed. So we appreciate the conversation going forward this session and look forward to working further with Representative Reyer and other members and other stakeholders on this issue. Thank you.
Okay, thank you. Is there anybody from the public that would like to speak on the bill? Okay, we're going to turn it to members' discussions. Representative Purcell.
Thank you, Mr. Chair. Thank you for bringing this forward, Representative Reyer. I am wondering, in line 3.10 on the third page, it talks about the working group must first convene by, and we heard praise for having a timeline. I'm wondering why that isn't filled in, what your process has been, and any other information. Thank you, Mr. Chair.
Representative Reyer.
Thank you, Mr. Chair, Representative Purcell. That will be part of the iterative process. I didn't want to unilaterally put in timelines. I want them to be feasible and aggressive so that people take it seriously so that we don't end up in a situation where we still don't have the work done and the time is caught up with us. But I feel that that needs to be part of the discussion with stakeholders and interested parties in the next few weeks. Thank you.
Okay, any other follow-up there, Representative? Okay. Okay, we go to Chair Bierman. Go ahead.
Thank you, Chair Becker. To the testifiers and to Rep. Reyer, I just wanted to hear a little bit more about building capacity and kind of the measurement of, we've been looking at a measurement of a benchmark. What other kind of markers would you consider important other than kind of that one that's been out there, which seemed unreachable, and when you compare to other states? And I just wanted to hear a little from many of you about that issue, please.
Vice Chair Reyer.
Thank you, Mr. Chair. Thank you, Co-Chair Bierman. So at first, when you said about capacity, I was thinking you were going to go to the infrastructure side, but we're talking more about the measurement side, I think.
Chair Bierman.
Correct?
Thanks, Chair Becker. So I think they're kind of related,
Of course.
right? So, either one, I think building capacity is important, but also what is our measurement going to be? Thanks.
Vice Chair Reyer.
Thank you, Mr. Chair. That's helpful. So from a measurement perspective, as I've thought about how we look at the continuum of dental experience, I think that the measurement that we have right now of individuals who've been covered for 11 continuous months going to a dentist once a month is pretty clean. It's pretty cut and dried what it is. It doesn't do a very good job of measuring oral health. I could be that person and go to one visit and then have a mouthful of cavities and never go back, but I would count. And so, I would like to see measures that say, how are we making progress in building access and accessibility? How many kids are getting screened and getting their sealants? How many people are going in for regular appointments like this metric does? How many people are being served at some of the innovative approaches that we're trying to use, the hub and spoke models, the move into mobile, so that we understand what's happening and then look at claims data to say, what are the outcomes looking like? So, I've made a good part of my career in a measurement sort of role, but there are people to the right and left of me who spend their time thinking about dental things. And I think amongst the group that is working on it, being able to say, how do we get a comprehensive approach? And to me, that's a really big priority, because I want to understand what works. I want to have evidence to say, here are the effective treatment, the effective engagement methods. I'm not talking about dental types of treatments. I'm talking about engagement options. Here's where we can focus. Here's what works well to reach people with disabilities, people in congregate living, people who are just, are mobile and active and relatively healthy, the whole spectrum, and understand it. My one thing that I would caution is that I know how easy it is to over-engineer things like that and end up with measurement burdens that aren't feasible, that take a lot of resource to collect and to gather. And so I want to look for that balance. There are a couple of things. There's a Dental Quality Alliance that the American Dental Association has. There's another system in Minnesota, which is more of a people saying, being surveyed about their oral health. I think there are lots of things to look at.
Follow-up, Chair Bierman?
Thank you, Mr. Chair. Thank you, Rep. Reyer, for the work on this, and I appreciate your diligence in this effort over a very long time, and being out there at the clinics and inviting me to tag along a few times. And just know that I know that you're doing the work, and I know that you look at this opportunity as a new beginning for this, and just want to help you get there. Thank you.
Okay, thank you. Vice Chair Nadeau.
Thank you, Mr. Chair. And I don't have any questions, Representative Reyer. I just want to make a comment that when this bill started out, you brought a lot of people to the table, and you made a lot of concessions, and you took a lot of input. And I think this is a really good result of that. And I look forward to watching this continue, and thank you for bringing it.
Okay. Seeing no further questions, Vice Chair Reyer, close, please.
Thank you so much, everyone. I look forward to having conversations with every person in this room. To me, that's the collaborative approach to get things like this that can be complicated and can easily go in unintended directions to do it right. So I look forward to it. Thank you.
Thank you. The chair lays over House File 1935 as amended. I'm sorry, typo, 1934. So the chair lays over House File 1934 as amended for possible inclusion in an omnibus bill. Thank you.
Welcome to the other side of the table, Chair Backer. Would you like to move House File 2464?
Yes, and I believe we have a DE1 amendment, DE1-1 amendment, Vice Chair Nadeau.
All right. We'll move that. What's that? I move that House File 2464 be placed on the general register, and that we move the DE1-1 before the committee in order to take amendments. Chair Backer, please describe the DE1-1.
Well, members, this is our health policy bill that co-chair, I should say Chair Bierman, and the two vice chairs and I had a wonderful time last Thursday and Friday talking about. So I will turn this over to, right now, Vice Chair Nadeau, to Ms. Clarquist to go through the bill with the members.
Ms. Clarquist.
Mr. Chair and members, I'm going to describe the DE1-1 amendment. Okay. I'm going to describe the DE1-1 amendment. This is divided into two articles, beginning with Article 1, the Health Policy Article. Section 1 is Representative Robbins' House File 2371, describing circumstances in which sensitive exams may be performed. Sections 2 and 3 are the base bill that's being amended. These make technical changes to two sections on environmental laboratories. Article 1, Section 4 is Representative Liebling's House File 1429. This permits the director of the Office of EMS to share pre-hospital care data on overdose incidents with ODMAP. Article 1, Section 5 is House File 129, Representative Rapinski's bill requiring the Director of Child Sex Trafficking at the Health Department to evaluate the Safe Harbor Program and report to certain members of the legislature every odd-numbered year. Article 1, Section 6 is Representative Agbaje's bill, House File 1105, requires the Health Department to conduct maternal death studies within the limits of available appropriations. Article 1, Sections 7 and 8 are House File 1903, Representative Novotny's bill, making changes to the Safe Place for Newborn statute. Article 1, Section 9 is Representative Bonner's bill, House File 89, modifying physician assistant collaborative practice. Article 1, Section 10 is House File 1011, Representative Bierman's bill, modifying the optometry scope of practice. And then Article 2 is Representative Bonner's House File 1165, making changes to the Higher Education Facilities Authority, renaming it the Health and Education Facilities Authority, and allowing it to issue bonds for health projects. And that's the bill.
Thank you, Ms. Clarquist. Chair Backer.
Yes, it's a lean and mean bill. So as you can see, it's a bipartisan bill. We took policies from both caucuses and addressing some of the concerns that our members have. And with that said, I know we have some amendments, so we could take those up. Yes, fine.
All right, members, we have two amendments filed for the DE1-1. We're going to start with the A1 to the DE1-1 from Representative Liebling.
Thank you, Mr. Chair.
Representative Liebling moves to adopt the A1 amendment to the DE1.
Yes, thank you, Mr. Chair. So I'm moving the A1 amendment. This is to the part of the bill on sensitive examinations. This was suggested by nonpartisan staff, and it is agreed to by Representative Robbins and Representative, I'm blanking on her name, Berg. Right, so this is just really to make the language a little bit cleaner, but we we all work very well together, and we think this will improve that part of the bill. So I'd ask for your support.
Oh, I love when we work together.
Thank you. Members, questions? Representative Zalesnikar.
Thank you, Chair, and thank you, Chair Backer. My question, I like many of the things in the bill.
This is the amendment.
Oh, sorry, not on the amendment, sorry.
All right.
My apologies.
We're on the labeling A1. All right. Hearing no further discussion, all those in favor signify by saying aye.
Aye.
Opposed? Same sign. Motion prevails. The amendment is adopted. Members, next we have the A2 to the DE 1-1. Who would like to move the A2?
And that's mine as well, Mr. Chair.
Representative Liebling, to your amendment.
Thank you, Mr. Chair. I'd like to move the A2. Apparently, I'm doing all the amendments tonight. So the A2 is to the piece of the bill that changes the scope of practice for optometry. And what it does is removes the expansion in scope around injections into the eye. So members, we've worked on this a long time. We worked on this the last couple of years, I think. And I have to tell you that I'm personally comfortable with the part of the bill that is expanding the scope as to medications. But I think we are being extremely hasty in expanding the scope of practice for optometrists to be able to inject needles into the eye. And what the bill does is as it is written now, it allows injection into eyelids, the muscles that move the eyes, and numerous spaces inside the eyeball itself, including areas underneath the retina. Now, there's a letter from the Minnesota Academy of Eye Physicians and Surgeons in your packet, and I'm using that here. But one of the things that's important to remember is that the eye is actually part of the brain. And I'm sure that it's not hard to imagine that this is something that if you were to do these injections, any kind of injection into the eye without proper training, you could do enormous amount of harm. And I really fear that by authorizing this as a scope of practice for optometrists, that we are really putting Minnesota patients at risk. When we license somebody to do something in this state, Minnesotans assume that that's because that is that the person who's so licensed is qualified to do that thing, and they don't usually ask any other questions about it. And so this is something we should do with extreme caution. I have been talking, there are several ophthalmologists here in the room. They are surgeons, doctors, physicians, and surgeons. And I've been asking them this evening about how many injections they do under supervision during their training, and the answer is hundreds. When the optometrists were here testifying on the bill, I asked them, and frankly, asked them last year and have asked them many times, what kind of training, how much training do optometrists have in doing injections? And the answer has never been a clear answer. It's been, well, some of them go and they do some in their training around the country. They've never been specific. They've never said. One thing I did hear, though, was that some have training, but not all of them. Well, when you pass this bill, you are saying it's okay for any licensed optometrist to do injections into the eye. And I know that the Board of Optometry sat up here, and I believe I asked about that too, and the board said, oh no, we can say that some people, or somebody said it, maybe it wasn't even the board member, but they say that not every optometrist will be allowed to do this. Well, that's just not accurate, because once we say that something is within the scope of an occupation, any member who's licensed can do that thing. So if we could be more specific there, I suppose could be language written that said that an optometrist could do this if they had certain training, if they showed the board that they had certain training, but that's not what's in the bill. So I don't expect that this amendment is going to pass, but I personally really want to be on record, and I'm going to ask for a roll call on this, Mr. Chair. I want to be on record saying that I do not approve this because I really believe, and this is not to me about anybody's turf. I frankly don't give anything for anybody's turf issues here. This to me is about patient safety for Minnesotans, and I really believe that if we pass the bill as is and allow optometrists who may or may not be trained, and some of them, I will give them, maybe if some of them are, but the vast majority, I do not believe, are trained to stick needles in people's eyes in this very broad way that this bill is doing. So I'm going to ask you to vote yes on my amendment, which just removes that piece of the bill. And this could continue to be worked on some more. As I'm saying, maybe there could be some more fine tuning around this, but as the bill is now, I believe this is putting Minnesota patients in danger. So I'm going to ask you to vote no. Thank you, Mr. Chair. I'm sorry, vote yes for the amendment.
Further discussion, Representative Gilman.
Thank you so much, Chair. I find some frustration with just this amendment being brought forward, as I feel like we just passed it through this past week, and here we are again. Scope of practice is something that, I'll just tell you a story. I'm going to tell you a story about myself. I was a registered and certified dental assistant, and I loved my job. I loved serving people. I loved doing whatever I could. Even bringing the bill that I brought forward, today with sterilization, that was part of my job. And for me, serving people to the best of my ability and making their experience enjoyable so they would want to keep coming back was my goal. And I just think about this bill that we have before us, and this amendment now is tying the hands of optometrists, saying, you've gone to college, you've invested the time, the money, the energy, you have a love for your clients, in your people in your practice, but we're going to tie your hands because we don't believe that you have the expertise to do that. I would be curious to ask anybody, just to understand, tattooing. There's some of us in this room that have tattoos. And I looked on the website, 200 hours you need to be able to take a needle, and tattoo people and be licensed in the state of Minnesota. So even eyelids.
Which I have.
And I was gonna say, are there members, some people will choose to get permanent, makeup tattooed on their faces. Now, as a patient or a client, I could choose where I'd wanna go have the best dental experience, where I'd wanna go get my tattoos based on, things I've heard from people, things I've seen from people. I get to make that judgment call. And I would think that ophthalmologists and optometrists would want to lock arms on this to serve the most people they can in our state. And I'm surprised that we would think that people that have spent that much time and expertise and training would just be willy-nilly with eyeballs. I mean, it's their business, and people are their business. So I'm disappointed that we don't trust people that have invested their life and their livelihood into this practice and caring for folks, that we wouldn't trust that they would have the best interest of their patients in mind. And I'll just say something too. I mean, I mentioned shingles before. We talked about medications and different things like that, and how time is of the essence with these things. And I just think if things were to go wrong, and we saw some horrific things in pictures and heard, horrific things that could happen, those folks won't be in business long if they're doing things that would be bringing harm to people. And that's what we learn about And I fully support moving forward and allowing optometrists to practice within their scope, to be able to serve more Minnesotans and make things more accessible, especially in rural areas. And again, I have ophthalmologist friends, retina eye specialists. I mean, I know people that have spent hours in their specialty, but I would think they would welcome having more help and support to serving more people. So, thank you.
Representative Carroll.
Thank you, Chair. And let me just say thank you, Representative Gilman, for your comments. And I appreciate them. The thing that I'm concerned about, and I think you are too, is patient safety. What's the safest thing for the patient? It's not what the provider's trained for or not. It's just, are they able to provide safe treatment? And ophthalmologists are trained to do surgery on the eye. Optometrists are not. So I don't want to mess with people's vision with someone who's not trained to do so. So that's why I'm going to support Representative Liebling's amendment. And messing with people's vision, I mean, it could be one and done. And something could happen by someone who's not trained and qualified to do the procedure, and it could be the end of their eyesight. And I wouldn't want to put our citizens in that position. So I'm going to support Representative Liebling. Thank you.
Representative Bierman, Chair Bierman.
Thank you, Mr. Chair. Members, this session, we had a hearing for the first time in years on the scope of optometry practice. It certainly was a convening of competing perspectives, and that continues tonight. What happens when professions cannot reach any sort of agreement? In these cases, it is up to state legislators across the country to intervene, to keep the practice current with professionals' updates, and make certain that we are helping our healthcare professionals to work at the top of their scope, no matter which profession it is. This improves our workforce. Minnesota should not be the very last state where optometrists can provide treatments they are educated to perform in optometry schools. As noted previously in the hearing, the prescribing of the 3 medications in this bill are already done in 43 states, 47 states, 49 states, respectively. The injections in this bill are already done in 25 states. All these injections are part of 4-year educational curriculum in the 26 optometry schools in the country. These injection procedures are authorized by the National Board of Examiners since 2012. State Optometry Board has an extensive rulemaking process before doctors of optometry could expand scope. As they do now, ODs will refer patients to MDs if the situation is beyond their scope. That is normal practice and procedure. Finally, there is nothing extreme here except the fear-mongering we have heard. Changes in the scope of practice happen over decades. We need to update all of them periodically. And the comparative data on current practice in this area of medical care signals that the time for Minnesota has come. Many graduates look at the states to practice based on the scope that can be performed at the highest level. We want them to consider Minnesota. We want them to choose Minnesota. Members, I ask you to please vote no on the amendment.
Thank you. And members, I have up next is Representative Bonner, followed by Rapinski. That's the list that I have.
Okay.
Representative Bonner.
Thank you, Mr. Chair. I will say in years past, I've been very vocal about this particular provision, and I have not shied away from it. You know, this idea of doing no harm, I mean, that is the fundamental of any medical practice where we put people at the center. And every single time we have asked specifically about training, we have gotten no answer. It has been crickets. And I hate to cite this, but it stuck in my mind in a previous session when they brought some of this forward. And I don't recall exactly which type of injection it was, so please forgive me if I misstate. But at that time, it was suggested that there were clinics to get certified or to get this training over a weekend. And I have to tell you, I have not heard anyone refute it since. I have not heard anyone give any other additional information on what kind of training there is for putting this in an eyeball. We're talking about intraocular injections, literally putting something in someone's eye. And I struggle with this bill because in all of that time, no one has provided the information we have asked for. If that information exists, then why are we not discussing it? I'm willing to be wrong, but I haven't heard anyone bring forward the information to give me enough confidence that this is safe and effective and that no one will be harmed. And my job as a legislator is first and foremost to look out for my constituents, to look out for their health and safety. And without that information, I'm sorry, but I find this, permitting this is really troubling. And they said, well, there's no problem with this. There's no issues with this. Where is the data? They have not provided that either. So I am going to support this amendment, and I would encourage others to do so as well. I have no issues with the medication portion of this bill. And in fact, it seems quite reasonable. But until we can have a deeper dive discussion on what these types of injections are and what those ramifications are, what kind of training has been there, what the data says, which we have not received any of it, I can't in good conscience vote, or I cannot allow something that could put the health and safety of my constituents at risk. For that reason, I will be voting for the amendment.
Representative Rapinski.
Thank you, Chair, and thank you, fellow representatives, for all the conversation on this. I sat and listened to this debate, comments, arguments for quite some time. And Representative Liebing, I'm going to disagree with you in how I remember those conversations being. People are talking about there's no data, there's no specific number of how many times I have to practice. I went through nursing school, and I trained on injections. And it took me a little bit longer, so I practiced more than my fellow classmates. You practice until you learn how to do it, and you pass that part of the course. So I ask you, have any of you ever been through classes like that, like an EMT? So I would say then, me too, as a fellow EMT, gloves on, scene safe, mechanism of injury. You learn it. You practice it until you pass it and you learn it. So when asking the questions of a testifier, how many times you practice that injection? And that testifier not being able to answer that question, it's unfair to say it's willy-nilly or nobody can give you that information. Because you know what? Everybody that gets trained in the medical field trains until they can do it. And these people are trained in this. And not to mention Minnesota loses out on all the opportunity of having them work for our state, but they train for this. And when you ask about details about injections, if a doctor's in here giving me a testimony about a surgery, I can't say that how he's going to fix a broken leg, and I'm going to know exactly what he's talking about. But I do trust that doctor's testimony, that what he's saying is true and honest. And if he decides he can perform that surgery or that fix, I would allow him to do it. I do not think any optometrist that has the intentions of doing injections, if he doesn't feel confident to do that, or she, is going to perform that. So I appreciate the fact when you say that you don't want to put fellow Minnesotans in danger and stuff. That's rainbows and unicorns. We all feel the same way. I don't think for one moment any doctor, optometrist, dentist, chiropractor in Minnesota is going to try and harm the potential client. And to assume that they would, I can't believe you guys even say that. Anybody says that. I just don't get that. You look at, I think you said the amount of hours, a four-year education, that and the amount of hours they train on this. They're being trained for this. To imply that they're not being trained for this procedure is wrong. because that is not the testimony I heard. And if you heard that testimony different, I would invite you to go back and watch it, because I did. So when you imply that those people, and I don't know those people that testified for Adam, but to imply that they were deceitful or unable to answer a question because they couldn't tell you how many times they gave an injection in school or in practice, really? You know, I have a fellow EMT first responder on this committee with me. I could ask him the same question. How many times did you pump a chest when you were doing your CPR training? He probably can't answer that. But I can tell you, he may have done it less amount of times that the person next to him had to do until he trained and got it right. These people are licensed, they're trained, they got it right, and we're trying to inhibit their ability to practice. I just don't understand that. So for the record, I am not supporting the amendment, and I do support the people that testified, and I do feel that we should vote no on this amendment, and that is how I think we're going to broaden the scope of that practice and allow people to do that, what they're trained to do for their jobs in Minnesota. Thank you, Chair.
Members, I'll just remind us, make sure that we stay away from motives when we're having these discussions. And Representative Hewitt.
Thank you, Mr. Chair, and I wasn't going to speak on this because I am supporting the amendment. I'm just going to let it go. But we talked about training, and in healthcare, we all get trained to our scope. The problem I'm having with this, because I have a lot of friends that are physicians, and they all did what we call a residency, and most of us around this table, I bet you every one of us knows what a residency is. It's a long, drawn-out process to make sure you're competent to do what you're going to do. And then after they do that, they may do a fellowship to make sure they're going to do what they're going to do. That was not the answers, and I don't think anybody around this table thought anybody was deceitful. And I'm sorry if that's what the interpretation was. The interpretation is the standard of what we see other people in the same practice go through. Representative Backer, and I guess we have another fellow EMT here too, we could do many things. And all we'd have to do is bring it to this committee and you would let me do surgery on the street. I think we're having some issues here because I'm not trained to do surgery on the street. I'm not trained to do any surgery. But if this committee decides I can, then it's opening a new door. And what's that training? Because the fellow EMT said you trained him? I think that, and I'm not trying to upset the wheelbarrow here, but I'm really looking at what we considered a standard for kind of surgical activity for injections. You just heard a former nurse or a nurse currently talk about the training they went through until they got it right. And that's the standard for training a nurse. What is the standard? Where do we compromise the standard on somebody that could actually cause major damage here to a major sensory problem in the body? And the representative talked about tattooing. Sure, that's a whole nother thing, but I think we're on a borderline here. And Representative Bierman, you did your work. You really did. But I think, again, somebody that's been through I got more certifications in healthcare than just EMT, and I know what I had to go through and the competency I had to show and what I had to, it's not just see one, do one, and teach one, it's do like 1,000 of them. And I think that we would be cutting, unless they can come forward with the residency program, that would be really a recommendation here. And so thank you for giving me this time. I'm going to support the amendment, and I didn't hear you acknowledge it, Mr. Chair, but there was a roll call called on this.
Thank you, Representative Hewitt. There was a roll call requested. There is a roll call granted. Is there any further discussion on the A1? Or A2, sorry. The clerk will take the roll.
Chair Backer,
No.
Chair Bierman,
No.
Vice Chair Nadeau,
No.
Vice Chair Reyer,
No.
Representative Bonner,
Yes.
Representative Carroll,
Aye.
Representative DePel,
No.
Representative Elkins,
No.
Representative Franson,
No.
Representative Gilman,
No.
Representative Hemmingson Yeager,
No.
Representative Hewitt,
Yes.
Representative Keeler, Representative Knutson,
No.
Representative Liebling,
Yes.
Representative Mahamud,
No.
Representative Perryman,
No.
Representative Purcell,
No.
Representative Rapinski,
No.
Representative Schumacher,
No.
Representative Van Binsbergen,
No.
Representative Zeleznikar,
No.
Sorry, first time I've done this.
We
There
see
being
that.
4 ayes and 17 nays, the motion does not prevail, and the amendment is not adopted. Any final discussion to the bill? All those in favor of the, Representative Zeleznikar.
Thank you, Chair. And I'm talking at the right time now. Members and Chair Backer, one of the things that, when I look at this bill that is disappointing to me is we have a workforce shortage. We graduate 4,000 nurses in the state of Minnesota a year. And the provision to have a temporary nurse license for the same type of thing with nurses that have graduated with their degree, have passed their boards, are potentially going to be sitting in an office, not working with their fellow nurses on the patient floor at a hospital, at a nursing home, at an assisted living, when they've been hired and they've been working because the board couldn't get the license done in 60 days. And of all the data that was presented, that Minnesota has the lowest amount of time for a temporary license, it's really disappointing because I'm on the workforce committee too. And there's not a nursing home, hospital, and if you're a patient, you're gonna hope that you have the nurse there that is graduated, can operate within their scope of practice. They've been hired. And they're gonna be sitting on the sidelines potentially for 30 days, for 60 days, because once that license is 60 days, they're sitting on the sideline. And it's happened, and it will happen again. And so, members, it's just shocking to me because Minnesota has 60 days it allows. No state in the union allows that. And we weren't willing to allow 30 more days on a temporary license when a hospital, nursing home, assisted living, disability group home has hired somebody when we do 24-hour staffing. So I will keep working this because we are the only state that is an outlier, and we have a critical nursing shortage. And this just adds more stress to nurses for their working conditions that we all care about that doesn't have to happen. The nurse is in the building. She's just sitting right behind the desk, reading, doing whatever they want her to do, or he is doing, instead of helping in critical care, whether it's starting an IV, being in the ER, it's just, to me, it's the same thing we did this for physician assistants, we did this for optometrists, not allowing people to operate in their scope of practice when we have the most severe working shortage, it is absolutely ludicrous to me that we would ask nurses to be in a stressful condition when we have nurse turnover, when it doesn't have to be that way 4,000 people are graduating in our own state. That doesn't even account people that move here, have already been practicing in Tennessee, in Florida, in Texas, but they move here. Maybe their partner or their spouse has a job, or they took the job, and they too have to get another license in Minnesota, even though they've passed their boards, and they've been practicing in another state. And they too will be sidelined. So members, I hope this is something that you will keep in the forefront of your minds, because it's really critical. We have 24-hour operations that are wanting every nurse in that building to be on the bedside when they have the scope of practice to do that. So thank you.
Members, the chair moves adoption of the DE1-1 as amended. All those in favor signify by saying aye.
Aye.
Aye. Opposed?
No.
Motion carries. What? The motion prevails and the DE1-1 is adopted. Now, the chair renews his motion that House File 2464 be placed on the general register as amended. All those in favor say aye.
Aye.
Opposed?
No.
The motion prevails and House File 2464 is placed on the general register. As amended. House File 2464 as amended is placed on the general register. I'm sorry, guys.
Yeah, good.
All right. Seeing no further business, the committee.
Chair, one thing. Can I say one thing quick?
Sure, you're the chair.
Okay, thank you. I just want to thank you, everybody. This is the first time that we have worked together on a bill. Might not be the biggest bill in the world, but we have made a step, and I do want to thank the colleagues on both sides of the aisle for working together to move this to the general register. It is a team effort, so thank you, members. That's all.
The committee is adjourned.